Hi, everyone. We're just going to wait a little bit for more people to join, and then we'll get started. All right, I think we can get started. So, hello and welcome to our webinar, where we will explore common misconceptions and uncover the latest research and insights about stuttering. We're so glad you've taken the time to join us live or later on the recording. This event is brought to you by the Michigan Medicine Department of Psychiatry. I'm Emily Garnett, and I'm also a faculty member working with my colleagues here, and I'm happy to be joined by them. Stuttering is a neurodevelopmental disorder where an individual's speech is disrupted by involuntary repetitions, prolongations, or blocks of sounds and syllables. It typically starts in early childhood and can vary in severity among individuals. Although there is no single cause, stuttering is thought to result from a genetic predisposition and neural processing differences. Stuttering affects about 1% of the population and about 5% of preschool-age children. Tonight, we'll hear from two of our Michigan medicine experts from the University of Michigan Speech Neurophysiology Lab, housed in the Department of Psychiatry, who conduct research on the neurophysiological basis of stuttering. We're also joined by Anthony Sun, a current University of Michigan student, who will share his insights from the lived experiences of a person who stutters. All right, so now I will give a little background on each of the speakers. Dr. Suen Chang is an associate professor in the Department of Psychiatry and the Rosa Casco Solano Lopez Research Professor of Child and Adolescent Psychiatry. Dr. Chang's research program focuses on advancing our understanding of the functional neuroanatomical mechanisms supporting speech motor control and the neural basis of developmental stuttering. Dr. Chang is also interested in developing novel treatment options for stuttering, including brain stimulation techniques that can enhance traditional therapy, as well as early interventions to help prevent long-term stuttering. Next, we have Dr. Shanley Trelevin, who is a postdoctoral research fellow in the Department of Psychiatry and a certified speech-language pathologist. Her research interests include neurological aspects of speech motor programming in individuals who stutter and potential relationships between stuttering and executive function. Anthony is an undergraduate student at the University of Michigan, planning to pursue degrees in computer science, linguistics, and math. He joined the Speech Neurophysiology Lab in the fall of 2023 and currently assists with EEG data collection for several of our studies. After graduating, Anthony plans to work in tech with a focus on improving the lives of people who stutter. Each of our presenters will give a brief presentation. If you're watching this live, you can submit questions at any time using the Q&A feature at the bottom of your screen, and we will pick some to discuss towards the end. We know that there may be many questions, so we will likely combine some that are on the same topic. And please know that our experts can't give specific advice for any individual situation you might be facing. If you can't stay for the whole chat or want to share the recording with a friend, you'll be able to watch this webinar again later on the Michigan Medicine YouTube channel. We will also send the recording to all registrants along with a list of resources mentioned in today's webinar. All right, so we can go ahead and get started, and Dr. Chang will be kicking us off.
Okay, hello everyone. Thank you all for coming to today's Mind Matters webinar, which focuses on stuttering today. My lab conducts research to try and understand how the brain works differently in people who stutter. By finding differences in brain anatomy and function, the thinking is that this information could pave the way to better diagnosis and treatments for stuttering, which is an important unmet need for this clinical population. Okay, so Okay, so before we start, first let me clarify that when we talk about stuttering, we are talking about developmental stuttering, where stuttering onset occurs in early childhood. This is the usual type of stuttering for the vast majority of cases. There are very rare instances of stuttering that first arise in adulthood due to psychological trauma or neurological insult, or in some cases, neurodegenerative diseases like Parkinson's disease. But again, these are much more rare, and there are some behavioral differences from developmental stuttering. So developmental stuttering can be categorized under the umbrella of childhood onset conditions called neurodevelopmental disorders. There are some commonalities found in these conditions, such as a skewed sex ratio, where more males than females are affected. Another common observation is that these conditions often co-occur. For instance, there is a higher incidence of ADHD and attention issues occurring among children who stutter compared to the general population. Stuttering affects up to 8% of all preschool age children, but most of these children recover naturally, leaving about 1% in the general population with persistent stuttering. If a child is still stuttering by late school age, there is a high chance that this is a lifelong chronic condition. Stuttering runs in families, but like in the case of other complex conditions, it is likely influenced by multiple genetic and environmental factors. Now, in terms of the brain, if we scan the brains of people who stutter, their brains look completely normal. It's not as if they have a deficit in brain anatomy or function in any obvious way that can be identified at the individual level with the current techniques. So, what has been reported in terms of differences found in the brains of people who stutter? A common theme that occurs is that when compared to people who don't stutter, people who stutter as a group show differences that do not get localized in any particular area in the brain, but the differences are subtle and they're oftentimes at the circuit level that affects the communication among different groups of regions that are interconnected by networks. So based on previous findings and theoretical perspectives, let me point out these three different neural networks that have been of interest in stuttering. So the first one shown here on the top is the left cortical, auditory, and speech motor areas, with the implication that disconnection between two major areas involved in speech and language, the auditory and speech motor areas, the breakdown here in the communication could really affect the fluid auditory motor integration that is necessary for speech production. The second circuit here is called the basal ganglia thalamocortical network, where functional and structural differences reported here for stuttering speakers were suggested to reflect deficits that affect things like initiating the movements that form speech sounds or sequencing the train of sounds and syllables that make up speech. And it also affects internal timing ability that support these processes. The basal ganglia thalamocortical network is well known for its role in movement control, as well as things like reward processing in the brain, but especially through the connections as are shown here in these structures through the basal ganglia, a deeper structure, specifically the putamen, which is an input structure of the basal ganglia, another cortical area called the supplementary motor area, SMA over here, and the premotor cortex. These areas form what's called the timing network that is of interest in the context of stuttering. The third circuit was on more of this cerebellar circuit, which with implications for core deficits that is squarely attributed to motor execution. So it also affects detection of error and fine movement adjustments. So this is kind of, in a nutshell, a little bit of a simplification, because the real picture is much more complex than this likely, and these networks also connect to one another. But I want to, for the purpose of this presentation, really focus on this network and provide very quickly three different studies that we have done that show that there seem to be differences in children and adults who stutter that really point to this network as being different in stuttering. So For today's presentation, I will go through three studies, as I said. For example, the first study, we find that in both children and adults who stutter, they perform differently in rhythm and timing abilities tied to the network that I just talked about. In another study where we looked at brain activity linked to speech planning and production, we also find differences in the basal ganglia thalamocortical network in children who stutter. And in another large-scale study that we looked at brain development in young children who stutter, we also found that the earliest markers that differentiated those children who would go on to have persistent stuttering could be differentiated in these major basal ganglia thalamocortical network. So that's the outline of the presentation. Let me start with this rhythm and timing aspect that I talked about. So it is well known that, and this is an interesting fact about stuttering, and that is the presence of what is called fluency-inducing conditions. And these include things like speaking in pace with a metronome, speaking in unison with another person, singing and reciting poetry. And, famously, we hear from the previous president that his stuttering was markedly alleviated by him reciting poetry, for example. So these kind of anecdotes are very well known. So why is that? So the thing about this is that in all of these conditions, what is known is that uh, all of these conditions have the commonality that they provide what's called this external pacing signal. So you don't have to rely on your own ability to internally time the movement of the speech, but because there's the external timing that is provided by, say, the metronome or rhythm of the song or what have you. So a question that can arise is, do individuals who stutter have a deficit in this internal timing generation? It turns out this network of regions that I talked about earlier in the basal ganglia thalamocortical network, including the main areas of the putamen or basal ganglia, SMA, premotor cortex, these overlap with those areas that support rhythm and timing abilities. And the connection among these regions are very heightened and strong in individuals such as musicians who are very good at processing and discriminating different rhythms. So we conducted a experiment where we played rhythms to kids who stutter. So it sounded something like this. And so the task of the kids were to listen to two of these rhythms, the same rhythms, two in a row. And then the third rhythm was either the same or different from the preceding two rhythms. And so this was basically a rhythm discrimination task. And in a task like this, what we found was that even though this didn't have anything to do with speech per se, we found significant differences between the stuttering kids and the non-stuttering kids. The stuttering kids did worse on a rhythm discrimination task. And we furthermore looked at whether this had anything to do with brain activity patterns. It turns out in children who don't stutter, the better they did on a task like this, the stronger the connectivity there was. There was greater functional connectivity between this basal ganglia region, putamen, and all of these network of areas that I highlighted earlier to be part of this basal ganglia thalamocortical timing network. So again, these areas shown in the timing network regions activated more, and together in children who don't stutter, the greater the functional connectivity here, the better they did. There was no such relationship that were observed in children who stutter. So that was very interesting to find. So in as an interim summary, we found through this study that there seemed to be a lack of connectivity in this very critical brain network that really support things like timing and rhythm processing, which also overlaps with those areas that really support timing of speech production. And so this clued us into whether there might be an internal timing deficit linked to this network in children who stutter. So a question might be, let's see here. So you might ask, so what about, so there appears to be some evidence to support rhythm and timing deficits in children who stutter. So what do we see in terms of their brain activity when the children are actually speaking? So in order to answer that question, we conducted a study where uh, uh, the children were asked to produce speech inside the scanner. So we wanted to examine continuous speech, but this is a very challenging task. It was thought to be a insurmountable challenge, actually, because the issue is that when speaking, we move our jaw, lips, and tongue, and facial muscles, and even small movements there, like these, could lead to significant movement artifacts that basically make analyzing images that are collected through fMRI impossible to be used for analysis. So it used to be that examining brain activity associated with overt continuous speech was impossible. There are other methods, such as listed here, that are more conducive to examining ongoing speech, but these each have substantial limitations. By the way, I don't know if you just caught that, but on the top, you might have seen a brain image with a significant movement artifacts. And then the bottom image was showing the algorithm that we used to handle and effectively remove speech-related noise in our fMRI data. So we were able to do this with an advanced spatial ICA method. I'll kind of fly through that technical details over here, but the main point is that we were able to capture brain activity patterns that we care about, which is brain activity associated with speech planning and production, and then taking away all the other noise and movement-related signals that were not of interest to us. During the scanning, what the children did was they were asked to do two types of speech tasks. One was to tell a story that was elicited through a picture like this on the left. Another was an automatic speech task where they were asked to count or recite the alphabet. We found that in children who stutter, so they were differentiated by peers who don't stutter during only the spontaneous storytelling speech task and not the automatic speech task. And the difference was significant in the premotor cortex region. Interestingly, when we looked at the period of speech preparation, we found significant differences in subcortical structures such as the putamen and the thalamus. And these kind of group differences also heightened and expanded as the children got older. So as an interim summary for the second study, we found that there were differences in brain activity that differentiated the children who stutter from their non-stuttering peers in this left premotor region during a speech task that is representative of when stuttering most commonly occur, but not in automatic speech tasks. And these subcortical structures that are included in the basal ganglia thalamocortical network that I talked about earlier, putamen and thalamus activity was also differentiated in stuttering children, especially during the speech planning task. And this kind of difference also increased with age. Okay, so as in the last part of my talk, I wanted to briefly go over a study that examined brain structure differences in children who stutter, especially those anatomical differences that can be captured early on that we have found to predict later persistence or recovery of stuttering. Okay, so much of my research has focused on pediatric neuroimaging, and this is quite challenging, especially with techniques such as MRI, because this is not what you would call a child-friendly technique. But although it's challenging, in my view, the expected outcomes are significant because stuttering, after all, starts during the dynamic preschool age period, and the trajectory of persistence or recovery also occurs during early childhood. The results from this research may help identify early neural markers associated with children who are most likely to develop chronic persistent stuttering. And these could then be used as prognostic indicators that may help guide clinical decision making, for instance, to prioritize early intervention for those who will likely not recover naturally on their own. Another potential outcome is that the research could help find developmentally appropriate neural targets for therapy development. For instance, if we find that certain aspects of brain development, such as functional and structural connectivity among specific brain areas, are consistently associated with children who recover naturally, we may be able to leverage this information on neuroplasticity to design new treatments to help enhance those connections. So the study that I'll talk about briefly now was based on a study that's been going on for more than 10 years, where we collected data from over 250 children, collecting repeated MRI scans for up to 3 to 4 years per child. We collected a detailed behavioral a battery of testing. We collected video samples of their speech. We did stuttering severity measurements, all kinds of standardized assessments measuring speech, language, and cognition. In terms of brain scanning, we collected 3 types of scans. And today I will be talking only about the anatomical scans that we did, that allowed us to look at gray and white matter volume differences occurring in the young children who stutter. Okay, so let me move on. So the interesting thing about this study was that all children who stutter that entered into the study met the criteria for stuttering based on multiple factors, including their speech patterns and parent report and clinician report. And because we saw these children each year, we could repeat the speech assessments and could determine later on whether which children seem to be in the recovered group and which children seem to be continuing to stutter. Usually, for the vast majority of cases, recovery, if it happens naturally, occurs within 2 years of stuttering onset. So we were able to differentiate these 2 different trajectories during a sequence of 5-year studies. Okay, so this provides a general schedule of events that occurred for each participant. For example, each child, they came in every year for 3 to 4 years. And during each of these visits, the aforementioned behavioral assessments were collected and 3 types of scanning were done. Let's see here. And because this study involved scanning children as young as 3 years of age, we had to do a lot of things to ensure that the children stayed still and comfortable while being in the MRI scanner. This is a picture of a mock or fake MRI scanner that we use to help desensitize children to the experience of being inside the scanner. We actually had a series of activities to help train the children to prep them for their MRI session, including showing examples of brain scans of where children stayed still. So you can see that on the left side, and not so still. That led to this blurry image. So they would get all motivated to bring home a good picture of their brains. Okay. And in terms of the method, we did a whole brain analysis that allowed group contrast analysis of gray and white matter volume. So I'll quickly go over the results. Okay, so the first question was, uh, the results that I will show in the next two slides give us clues into what might be the earliest occurring brain structure differences in children who stutter, and especially those who are likely to continue to stutter. So in the gray matter results, what stood out was that this area called the putamen that I've been talking about from earlier slides, here the children who would later go on to have persistent stuttering, when we looked at the brain scans of those children early on that we collected when they were younger, it was in that area that showed up significantly different among that differentiated the persistent kids from the control as well as the recovering kids. And in terms of white matter, we found that white matter volume decreases were also found to be significant in the persistent kids compared to the other two groups. And these white matter regions overlap with those areas that have white matter fibers that interconnect between the auditory motor cortical areas as well as between cortical and subcortical areas in the brain. Okay. In some cases, we also found that the gray matter volume correlated with stuttering severity, where in the case of left putamen, for example, the lower the gray matter volume here, the more severe the stuttering was. A similar result was found in the cerebellar region linked to motor control. So what about differences between those children who went on to recover from stuttering and those who continued to stutter? So these differences were mostly in areas of white matter volume. And we found, interestingly, that in the recovered groups, they showed a significant increase with age in these major white matter tracts that have a lot to do with connecting between major auditory and motor regions of the brain, as well as projection fibers that might be connecting between cortical and subcortical areas of the brain. And in fact, the recovered kids not only overshot the persistent kids, but they seem to even be a little bit more, go even higher than the control groups in some cases. Okay. And this was also shown in another type of brain scan, diffusion tensor imaging, where we also found that the recovered group seemed to show a very different developmental trajectory compared to persistent kids who stutter. So I'm going to wrap up here. So the results here seem to point to possible deficits in this basal ganglia thalamocortical network that I've been talking about. And these deficits, importantly, seem to be present early, near onset of stuttering, which was not shown before this study. And the significance of this finding is that if the connectivity within the basal ganglia thalamocortical circuit is not well developed, there's implications for timing and initiation of motor sequences that could be disrupted. And these disruptions can lead to disruptions in timing of the initiation and termination of the phoneme that is characteristic of the types of stuttering that we see among people who stutter. Okay, so this is my last slide, but in terms of translational work, these kind of imaging analyses have kind of guided us into being able to know what areas we could possibly target for studies that involve neuromodulation. These are type of studies that involve non-invasive brain stimulation. And what this does is it plays up the effects of behavioral intervention, where it can augment the effects of behavioral intervention. And in this case, we've been experimenting with fluency-inducing conditions so that we could play up those effects by targeting brain areas that affect timing controls. So these are being tested in the lab and by other labs at this time as potential newer methods for intervention in stuttering. Okay, so I'm gonna stop there. Thank you for your attention, and I'd be glad to answer any questions at the end of the webinar. Thank you.
All right, well, thank you so much, Dr. Chang. Dr. Trelevin, you are up next.
Hello. Okay. Thank you all for being here. I'm going to talk about tackling myths and misconceptions about stuttering. Everyone can hear me okay, right? I think so. First, I want to ask everyone, do you think that everyone stutters to a certain extent? So think about this. The answer is no. Everyone does produce disfluencies, though. So not everyone has perfect speech. Actually, all of us have imperfect speech, but not everyone stutters. The difference is people who stutter differ in terms of the kind of disfluencies that they produce and the amount. So this is key. So in normal speech, so someone who doesn't stutter, this is effortless. This is very flowing. There's a certain prosody to it that people might take or study in their linguistics courses that they've taken. It's very rhythmic. I know we learned a little bit about rhythm areas of the brain in the last presentation. And it's just not as much broken up. Normal disfluency is when maybe someone is thinking about what they want to say, and there are these kind of breakdowns in that natural flow of speech, but it's something that is more typical. So this could be a phrase revision, a interjection, and I'll show you what this looks like. So this could be a repetition of a phrase, she isn't coming with us, or an interjection, so that or an buying time before you think of what you're going to say next. A revision, she isn't coming with us. So this is something everyone does. So for stuttered speech, this can sound a little different. Except this first one here is actually something that you'll see a lot of people do even if they don't stutter. And this will be a whole word repetition. As I go down this list, they get more severe and more unique to stuttering. So a whole word repetition would be she isn't coming with us. And also I mentioned the amount of disfluencies. So someone who stutters would have more repetitions here than someone who doesn't. And they might actually have more of the normal disfluencies, like those ums or uhs that I talked about before. Their sound syllable repetitions. This is a little more severe. She isn't coming with us, or the prolongation of that sound, sound here. And then the most severe form of stuttering is a block. So this would be when the sound is stuck. This is part of that hallmark loss of control that people experience during stuttering. And this is a big difference from someone who doesn't stutter, because someone who doesn't stutter, when they're producing a disfluency, they still have control over their speech. For stuttered speech, there's a loss of control. That word is getting stuck in their throat, and that's how some people might describe it. Some people might call a block a silent prolongation, and this would be just no sound coming out until they're able to speak, and there would be a variable amount of time that these stuttering behaviors might last. So this is what stuttering can sound like. And if you notice, I kind of pointed to my throat when I was talking about blocks, because there's a look to stuttering too that people experience. Secondary behaviors for stuttering can be counterproductive. They could be something that someone might do in order to not stutter, like looking away or opening the jaw, having that muscle tension or pursed lips, tension in the mouth and neck, eye blinks or grimaces. during a moment of stuttering. Sometimes people might change words in order to not stutter. For some children, I've seen them like beat a limb against a table to try to get out of a moment of stuttering, or maybe someone might not speak at all in order to stutter less. This can become more automatic and become more prevalent over time and experience with stuttering. So this would happen less in younger children. And this can often be more distracting. So if someone is, pursing their lips or blinking really hard, this could be more distracting than the stuttering itself. And again, this can increase with age. So if you can imagine, stuttering is something, if you were a person who stutters, that, they would experience all the time when they talk. And it's very variable. It can be unpredictable. So there are going to be some feelings associated with this. Some of these internal behaviors might be negative perceptions of communication abilities. There can be low self-esteem related to stuttering. And I want to point out that this isn't true for everybody. So I've met people who stutter very severely and their self-esteem is not impacted by stuttering at all. And I've also met people who stutter very mildly. I've hardly noticed it, and it really bothers them and impacts them. So everybody's very different in these experiences that I'm talking about. People might internalize the negative reactions from others. And they've had bad experiences about how people react to their stuttering. This can result in a fear of speaking or social phobia, isolation, especially for people who've never met someone who stutters before, depression and anxiety, sometimes body image difficulties, and covert stuttering, which is when they might try to hide stuttering and make sure people can't tell when they stutter. And all of this leads into what we call the iceberg of stuttering. So the stuttered speech itself is only the tip of the iceberg, these overt behaviors that we can observe as a listener. But what we can't necessarily observe on the surface are those more covert behaviors, like the shame and feelings of guilt, isolation, denial, fear, anxiety, and hopelessness that some people who stutter experience. And this is really important for speech pathologists like me because rather than only addressing the speech fluency, we need to view them as the whole person and the whole experience. That's why we have measures of the negative impact of stuttering that are really important for us so that we can, help them work through everything that they're dealing with stuttering that is, way more than just the speech disfluencies themselves. And the kind of perspective of stuttering from the public has not helped with this iceberg and the feelings associated with stuttering because unfortunately, stuttering is still very misunderstood by the general public. I think as a whole, society's gotten a lot better about neurodivergent populations and neurodiversity. But stuttering hasn't caught up to that yet, and I'm hoping that will change. But for instance, in the Harry Potter films, Professor Quirrell is a very anxious person who stutters, which is a very stereotypical way of talking about stuttering. But then when he goes full villain era and gets all of this confidence, he stops stuttering. Or in Waterboy, he had a lower level of intelligence and stuttered, and this is not helpful to the general perception of stuttering. Nor is it accurate. Again, people who stutter are extremely variable. We call it a very heterogeneous population for a reason. And everyone who stutters might sound different. They might experience differences. I've worked with focus groups where people can argue about whether something, about their perspectives of different parts of stuttering. Everyone experiences it very differently. So it's really hard to stereotype people who stutter. So now I'm going to get into the myths about stuttering and what might have caused stuttering. The less common myths include maybe allowing an infant to look in the mirror or tickling a child too much, cutting the child's hair too soon, or the mother sees a snake when she's expecting, dropping a baby or the child being scared too young. Some more common myths are that stuttering is caused by high emotional trauma. Dr. Chang mentioned in her talk that we are talking about developmental stuttering. Stuttering can be caused by trauma if it's psychogenic stuttering, like if someone goes to war, and that can be related to stuttering, but it's a different kind. And like she said, it's more rare. So yeah, developmental stuttering is not caused by emotional trauma. People who stutter are certainly not less intelligent. I give IQ tests to people who stutter all the time. And especially now in Ann Arbor, I have seen just amazingly high IQ scores from people who do and do not stutter. So that's not accurate at all. Stuttering is not contagious. And people stutter on, all kinds of different sounds. One thing to note is that people do not stutter because they are nervous or anxious, which is a very common stereotype. And I'll talk about it a little bit more in a minute here. And this one's pretty common, that people think persons who stutter need to think before they speak. This is actually something that as a clinician, I use to help differentiate who does and does not stutter. If someone needs to think more about what they're about to say and then they stutter, then they probably actually don't stutter. They might have a disfluency, right? But if someone knows exactly what they want to say and they're losing control of their speech and the words are getting stuck, that is more what stuttering is. So that's actually something that I might use to help determine if someone stutters or not in a clinical setting. So the monster study is a study that came about because there was a myth that parents cause stuttering. So this is the diagnosogenic theory of stuttering. And Wendell Johnson and his student Mary Tudor, they wanted to study if parents cause stuttering by considering orphans, which, yeah, it doesn't go well. There's a reason it's called the monster study, but they wanted to see if they could induce stuttering in these children. And they berated a group of children about their speech and were horrible to them. And then there was a group that they were kinder to about speech. And they thought that maybe with the group that they berated and said, your speech sounds terrible, you're stuttering, even though they weren't, that they could induce stuttering in that group. And they did not. So what we learn is, first of all, you cannot induce stuttering in children. Parents do not cause stuttering. And also, it is a very good thing that we have better protections for participants now. This study is certainly one that's taught us to do better by study participants and keep them safer. So I'm going to do a little game now of fact or myth. So I'm going to pause before I tell you whether each one is a fact or a myth. And I want you to think to yourself, okay, do I think this is a fact or do I think this is a myth? You should know this one because I already said it. Fact or myth? People stutter because they are nervous. This is a myth. Just think about all the people you know who have high anxiety or maybe anxiety disorder and whether they stutter or not. I know I would know a lot more people who stutter if everyone who is anxious stuttered. But I do think there is a relationship between stuttering and anxiety, in that sometimes stuttering, of course, can cause anxiety. So think about it that way. Okay, so we learned a little bit about this from Dr. Chang's talk. Does everyone grow out of stuttering? And I've actually heard this a lot, even from professionals. No, not everyone grows out of stuttering. So from Dr. Chang's talk, we know that some children persist in stuttering and some children recover from stuttering. So about 80% or maybe a little less do stop stuttering in childhood, which means 20% or maybe a little more of these children keep on stuttering. And we currently can't just look at a child and be able to tell the family, yes, you will stop stuttering, or no, you will continue on stuttering. So it would be really harmful for us to tell every family, yes, your child will certainly stop stuttering, when there is a good proportion of them that will continue on. And this is something that was a little bit touched on in Dr. Chang's talk as well. Do about 1% of people stutter? And that is a fact. So this one isn't a myth. 5% of children stutter. About of the 5 end up stopping stuttering, so they recover from stuttering, leaving about 1% of the adult population who does stutter. Okay, fact or myth. People who stutter prefer no eye contact while speaking. Yeah, this is a myth. Definitely try to be with that person in the moment when they're stuttering. So keep eye contact. No one would say they prefer no eye contact. Okay, fact or myth, that telling a person who stutters to slow down, take a breath, start over, that's helpful. Definitely a myth. That would probably just, annoy someone and sound a little bit condescending. And I will, in my next slide, which will be my last slide, so I'm wrapping up a little bit here, talk a little bit more about some tips for, being a good listener when you speak to someone who stutters. Okay, fact or myth, people who stutter can hide stuttered speech. This is actually a fact. A lot of people can change their words to hide stuttered speech, or maybe they speak a certain way or speak less. In clinic, I've met people where they came in for speech therapy, and it took a few weeks for them to feel comfortable enough to stutter around me. So sometimes people can hide it. So again, think about that iceberg analogy that I showed you at the beginning. There's so much more going under the surface that we don't know about. So just because you might not see it or observe stuttering doesn't mean something isn't going on. Fact or myth, preschool age children are aware of their own stuttering. This is also a fact. So children as young as age 3 are aware of stuttering and are aware that their speech is a little bit different. Okay. Is it fact or myth that sometimes it's helpful to finish the sentences for someone, or finish a sentence for someone who stutters? This is certainly a myth. I always think about my friend James, who not only, he says this happens all the time to him, but he says that normally when people finish his sentences, they're wrong about what he was going to say. So it's not even accurate. As a speech pathologist, I don't like to see people finishing the sentence of someone who stutters also, because then you're not letting them speak for themselves. You're taking that opportunity for them to speak away. So either way, this is not helpful. So I do not recommend that. And then the last factor myth, is stuttering most common on single words? This is a myth. Stuttering is actually most common on longer sentences or more complex sentences or utterances. Actually, a way someone can hide stuttering would be by speaking in like one-word utterances or shorter utterances. So that one's a myth. All right, so my last part is just talking about being a better listener for someone who stutters. Again, maintain eye contact, be there with them in that moment, and give someone time to say what they want to say. I often recommend leaving a beat after someone, if you're talking to someone who stutters, after they finish speaking, just to make sure if they might be having a moment that's silent of stuttering and they're not trying to say something else. So just give them a little bit more time so you might not accidentally interrupt them. And of course, don't interrupt them if they're having a moment of stuttering. Just let them say what they want to say. Obviously, don't finish anyone's sentences. Avoid any unnecessary advice. And people mean well. I think all of us, because we all speak all the time, we think of ourselves as experts about talking, right? If, talking is something we do a lot. But it's probably not going to be helpful, and it might make someone, even more hyper aware of their speech, which leads me to just be aware of your body language and your reactions to someone who might be stuttering, because they are paying attention and they are clocking it. So just be there with them, be an ally for the stuttering community, and maybe we can change some of these myths and perceptions about stuttering. That's all I have. So thank you all for listening, and I'll take questions at the end.
All right, thank you so much, Dr. Trelevin. Next up, we have Anthony, and we'd love to hear from you now.
Hello, everyone. Thanks for tuning in. I'm a rising junior at the University of Michigan, and I've stuttered all my life. Those who don't stutter are often in the dark about the experiences of those who do, and sometimes unknowingly say things that end up being hurtful. So I'd love to take a moment today to share my lived experience as a person who stutters and discuss the aspects of stuttering beyond the surface, ones that you don't really consider as someone who doesn't stutter. For me, stuttering is like a middle manager in my brain who wants to approve of each phrase or utterance I want to say, but as an additional layer of management goes, has a response time much slower than the rate at which I could think of what to say. As a result, the words that reach my mouth to produce speech are staggered and behind schedule, which makes me feel short of breath as I scramble internally to maintain a good image, while the conflicting signals continue to make me produce a labored speech. As such, when I engage in conversation, especially with people that I've never met before, it's often a high pressure balancing act for me. Well, while the other person probably views it as more of a casual interaction and has no clue that I stutter until I start speaking. Since for people without speech disfluencies and are fluent in their native language, they could speak without much conscious effort. One of the big frustrations I have with stuttering is the information gap between me and the person I'm speaking to. Since stuttering is a relatively unknown thing, I don't know how much my conversation partner knows about it, nor how they will perceive it, nor how they will react. So the onus is on the listener to, to understand. With the dozens of conversations that I, I can have in a day, it's impractical to always announce my stutter. And besides, it also feels awkward to start a conversation that way. So what I grew up doing to try to minimize friction is to mimic a regular non-stuttered speech, which adds another layer of pressure in an already high pressure situation. When I inevitably stutter for the first time, that is also the listener's first exposure to it, and it's hard for the listener to not react instinctively, which is often a brief look of shock and repulsion. It's hard to blame listeners for instinct, but with accumulating looks of shock and no choice but to power through the day producing stuttered speech, it really feels like a vicious negative feedback loop that feels impossible to escape from. Growing up, the hardest times I had dealing with my stutter were in middle school. When I had to present for class, after I memorized the script for my speaking part, I would practice saying the specific words or phrases I would stutter on the most as a muscle memory exercise to get any edge over my stutter. This was often futile, as class presentations were every bit stressful as a conversation, but with a room full of listeners rather than just one. It was frustrating that after hours of practice, when the dreaded half hour finally came, I would still start stuttering severely after hours of practice, and it felt like I was perceived to be not performing up to par with my peers, and that I didn't put any effort into practicing at all. When I came to the University of Michigan, I started working with the Speech Neurophysiology Lab, which was an immense paradigm shift. I spent my life trying to hide and work around my disorder, but here I felt like I was putting it on a pedestal and working directly with it. What I learned was that I spent my life in the dark about a lot of things, and I really lacked information and support. So I worked with the lab and my co-founding partners, Sydney, to start a stuttering support group in Ann Arbor, hoping to prevent people who stutter from having to live through the arduous experience alone. In my experience talking to people who stutter in these kinds of environments, the emotional layer of being afraid of others think and how I'm perceived is no longer an issue, since everyone knows that that feeling equally well, which is unbelievably liberating. Not to mention the feeling of community and kinship when we discuss a topic that we usually try to repress in our everyday lives. As with all kinds of support groups, it is incredibly reassuring to learn that many of our thoughts, worries, and experiences are not unique, which makes the the whole experience less scary. If you're tuning in from a location near or in a city, odds are there is a National Stuttering Association affiliated support group nearby, or if you're in the Ann Arbor area, you can stop by a two-star support group, which I help lead. Here I have some information on screen about the support group, and we would love to drop by if you're in the area, or also virtually if you prefer that option, or if you're too far away to join us in person. And I'll leave this up for a brief moment so you guys can get that. Thank you so much.
All right, thank you so much, Anthony. And thanks to all of our speakers. If all of our speakers could turn their cameras back on, we will begin the question and answer portion of the session. So audience members, we are moving on to your questions, and we do know many of you submitted questions actually before when you registered, so we'll try to answer some of those. If you have any questions, you can still add them in the Q&A now at the bottom of your screen. And if you have a specific person that you would like to ask your question to, you can note that as well. So I noticed that Dr. Chang did answer some questions in the Q&A already. But we can start with what age is stuttering usually diagnosed, and how do you tell if words or sound repetitions in speech change to being not considered developmental only? Anyone can answer that question.
Maybe Shanley can answer that better than I can, because not to put you on the spot, Shanley, I'd be happy to answer, but yeah.
Yeah, typically stuttering starts when language gets a little bit more complex around age 3. And typically within the first, couple of years of stuttering, that's when recovery might happen. What was the question about the developmental? There's like a second part to that question, Emily.
Yes. When do word and sound repetitions in speech change from being considered developmental to being stuttering?
Oh, I think it's less about changing, and I think it's more about, oh gosh, I'm going to use a term that might be outdated, but what I've heard before is unambiguous stuttering. So it's like that loss of control over speech. Is that struggle happening? So I think some people or some children, they might have a lot of repetitions because they're little language learners. So they're trying to figure out, what am I going to use this past tense ed? Am I going to use a copula, a plural? What linguistic form am I going to use now? And how am I going to copy who I'm listening to in terms of these sounds? And they might have some sound repetitions and word repetitions. I just had a repetition. I do not stutter, just because they're thinking of what they're going to say and they're still learning. Whereas you can see that loss of control. You can see that they're struggling to get the word out. And I would say that's the big difference with kiddos and how we would determine if it's stuttering or if it's, okay, they're just, figuring out, languages. And we do see a higher prevalence of these repetitions in children that might speak more than one language because they're learning linguistic forms in different languages. So yeah, look for the struggle.
Just to add to that a little bit, I wonder if the questioner, by asking whether something is developmental versus something that would lead to persistent, there is kind of a misconception about stuttering being developmental to mean that everybody that has this condition, if it's developmental, they're supposed to grow out of it. And that's not the case. By developmental stuttering, all we're saying is that this is a disorder condition that has the onset of symptoms that occur during childhood. And while most of these kids, up to 80%, grow out of it, some don't. And this can be persistent and chronic through adulthood, through the rest of your life. About 1% in the population, that's more than 3 million Americans. So I think even insurance companies sometimes, I don't know if that's still the case now, but would refuse to reimburse, saying that this is supposed to be a developmental condition, and that's just a misunderstanding of the nature of developmental stuttering. Okay, I see a question that just came in about medications in developmental stuttering. There was only one medication that went through clinical trial, and that was called Pagoclone. And it was initially a medication that was designed for anxiety. And it was effective in some cases, so that's why the drug company started it. It ultimately failed as a drug, so we don't have any FDA approved medications for stuttering at this time. Now, there are some medications, especially dopaminergic medications, risperidone, haloperidol, for example, have been prescribed. This is not the usual recommendation, however, because it could lead to very varying effects. It could actually make things worse in some people who stutter, although it could have some effects, positive effects in others. There just hasn't been enough research that has been done. There's been no further clinical trials to be able to confidently recommend anything. That said, I'm not a medical doctor. There are psychiatrists that may be prescribing this. This should be done on a case-by-case basis. But many people feel that the side effects associated with taking the drugs are not worth the try. So yes, it's a somewhat controversial topic, but yeah, I'll stop there. Shanley or Anthony, if you have any other things to add.
All right, well, I see a question for Anthony.
Mhm.
Actually, there are two questions for Anthony. First, did you receive services for stuttering? And if so, what technique or approach was helpful to you?
I actually haven't gone to speech therapy for stuttering. Um, what has been helpful is kind of just warming up my vocal cords before going into an environment where I have to speak a lot. Um, and I guess also just desensitizing myself from that aforementioned like a negative feedback loop by like having more varied social interactions and just like feeling like I have a better grasp on what's going on, because often the reason why I stutter the most with people that I have not met before is because I don't know what they're like, and like I don't know what their personalities are, and so it feels like I'm kind of talking to a black box. So kind of having more of that is helpful. Um, as a general tip for people who stutter, um, I can only say this. Um, it's something that someone mentioned to me before, and I thought it was uh, extremely helpful. It is to change your uh, goal in a conversation or a social setting from or rather changing your your metric of success from talking perfectly fluently in a conversation to having X number of conversations or being able to converse fully with someone. And if you treat that as a success instead of dwelling on a failure if you don't succeed in being fluent, it really helps with building up that social courage and kind of like internal feeling of rather of if you failed or succeeded.
All right, thank you. Another question has come in. Are there studies on cultural perceptions or considerations related to stuttering? Anyone can jump in.
I'm not well versed about any studies that might have. I'm sure there might have been. Um, Recently, I've been involved in a cultural adaptation study to implement a intervention in South Korea. And the thinking was that this is a much more ableistic and hyper kind of competitive society compared to in the US. So is intervention, let's say, that is more focused on acceptance of stuttering and stuttering openly, is that going to be as accepted in this society than the US? So there were that kind of assumptions being made in terms of what the reaction to stuttering would be in these cultures. I think even in the U.S. it was much more difficult in the decades past. It turns out in South Korea they're not as different than how we view stuttering, and they're much more open to understanding stuttering and accepting stuttering as a different way of speaking among people who stutter. So that was an interesting finding, but I'm sure there are pockets in different culture where this is viewed with more stigma, say, because there's still a lot of misunderstanding and misconceptions about the disorder. Does anybody want to add to that? Maybe Shanley? I keep putting you on the spot, sorry.
No, I think that's really well said.
Well, I have one maybe that Shanley could answer. What should I do if I think my child is stuttering?
That's a great question. That's a very it's a quick question. So I believe the first thing you do is you need to go to your pediatrician and get a referral for speech pathology, because if you think your child might be stuttering, you want to get them checked out. And I think there is a wait here of a little bit. So you would want to get them in to see an SLP. And even if you think they might recover from stuttering, it really is helpful to get them in speech therapy regardless, if they are in fact stuttering. So just get that referral in as quickly as you can, just in case. It's not going to hurt anything.
Anybody want to add anything to that? All right. I have a question that we can ask. Maybe more of in a general way. Can you talk a little bit, Dr. Cheng, more about how we might use brain stimulation with stuttering?
So when people think about brain stimulation, they maybe think about deep brain stimulation, which is a very invasive technique, requires neurosurgery. It involves inserting a probe in very deeper structures of the brain. Some of that is happening in terms of research, but when we talk about brain stimulation, we're talking more about non-invasive techniques. that involve electrical stimulation through electrodes that are put on the scalp. And we deliver a very weak current to that has been shown to either increase or suppress activity in the underlying region. So what we've tried to do and others in the field, there's not many, but for example, a group in Oxford has used this brain stimulation technique to help increase activity in the left Broca's area, inferior frontal gyrus region. And they did this for, what was it, about a week or something, intensively like that, in conjunction with a fluency-inducing tasks such as choral reading and they did find a significant reduction in stuttering. But the catch was that the reduction in stuttering was only during a reading task and not conversation. But the other promising thing, though, was that the effects of the stimulation was still there after 1 month. So I think there is room to kind of continue delving into this. But yeah, it's an active area of investigation that has a ways to go. But the thing is, we are able to do something like this because of accrued findings where we know where to target, or we have some candidate regions where we'd like to increase activity or suppress activity or really stimulate functional connectivity between different regions. So that's the goal of these kind of non-invasive brain stimulation interventions at this time.
Thank you. A question has come in, wondering about stuttering and English language learning. Recently evaluated a student with onset at the same time as English was introduced. She had significant secondary characteristics, but her stuttering seemed to resolve before any intervention. Are there any guidelines available to differentiate stuttering related to English language learning?
Yeah, this is very interesting and kind of an unusual case. Shanley, did you want to talk about that?
Well, I have thoughts on this, just because it is common with children that are bilingual. There was a study that looked at children who are Spanish English bilingual, and I think the majority of speech pathologists actually misdiagnosed a child who didn't stutter as a child who stuttered because there were so many disfluencies. And it's about the language learning I mentioned earlier. So this actually kind of makes sense to me a little bit, although the secondaries are what's throwing me, right? Because that's more of something you don't typically see, but I still think keep an eye on it for that because the secondary characteristics occurred. But if if it seems to have resolved, which is what it looks like from the question, it seems like maybe this child, worked through whatever was going on. And I do think that increase in, complexity, the two languages, maybe these recent changes involving learning a new language might have been related to this struggle that was observed, but I mean, it looks like it resolved. But it is, again, very common to misdiagnose stuttering in children that are learning multiple languages. And you have to look for that struggle to be able to differentiate if it's stuttering or not, that really getting stuck that children experience.
Great, thank you. So I have one more for Anthony. I think he is typing an answer to a question that came in. However, Anthony, how has your stuttering changed over time, if it has?
I believe it has increased and decreased over time, with the peak being around 12, 13 years old. According to my parents, I started to stutter around the age of like 8 or 9, around like fourth grade, and it was a big worry in middle school. As I've met more people and been in more social situations, it has gotten better. And if I'm in the right headspace, I'm able to like speak fluently for a duration. But like back in middle school, basically every sentence was stuttered. Yeah, so it's been on a gradual decline, but I still do stutter frequently now.
Great, thanks. So there are some people who may be able to accept their stuttering and not want treatment. There are other people who want to have strategies to increase their fluency. Are there good strategies for that? Or how can we balance acceptance versus treatment?
What a great question. I think, again, it's Shanley. You've put a lot of thought into this, more than I have.
Gosh, for me, it's the person and what their needs are. I mean, I think I might have mentioned in my talk that I've met someone who was so bothered by their stuttering. And I would probably focus more on fluency enhancing strategies with that person. But then there are others who they want to work more on saying what they want to say. My biggest goal is high quality of life, not letting stuttering prevent anyone from doing anything or saying what they want to say. But as a clinician, I think we have to listen to the individual and what their need is. Is there a great wealth of literature that suggests that our current techniques to create fluency for someone who stutters, that it works? No. That's why Dr. Chang is working on what she's working on to improve techniques so people can have more options. But there are some tricks we can use to try to help someone get out of a moment of stuttering a little more easily, I would say. But nothing we have right now is going to make someone more fluent on a permanent basis. There's a very high relapse rate, but I think we just have to listen to the person and what they want and respecting that. So I try to listen to the person, the individual and their families, and I try not to bias them too much.
So, yeah, that's great, Shanley. Just to add to that, about the techniques that are used in current speech therapy right now, they can be very helpful. So it's just that it's not going to completely cure your stuttering. There's no cure for stuttering right now. However, these techniques can significantly decrease struggle in speaking and help you learn ways to get out of that kind of stuck feeling when you need it. So we don't like black and white kind of recommendations. So I think there is a role for speech therapy and these techniques for sure for many individuals. On the other hand, other types of research have shown that if an individual is so obsessed with being perfect in their speech and being fluent, that's actually something that is hurtful. That actually undermines you, because by being in that, I think Anthony said, headspace, if you really are trying to appear like that, that creates more pressure on yourself, and that leads to, in terms of like neuroscience terms, there could be more, dopamine and dysregulation of motor timing. And that's why, people who stutter more in social situations and stressful conditions, because they have this performance mindset, right? Whereas you don't stutter when you're on your own or you're speaking with a puppy. So I'm kind of going on a side track here, but this is just to say, so I think there's a role for both acceptance as well as treatment. And as Shanley says, I think it really depends on the individual and what their needs are.
I would agree. All right, somebody sent us a myth or fact question. So, myth or fact, targeting articulation errors with a child who stutters may increase stuttering behavior.
Ooh, I like this question. And yeah, I guess I'll take this one, but I'm really curious if anyone else has opinions on this. But I don't know. I could see it maybe it could maybe bring about more stuttering if working on articulation is getting the child to speak more, right? Or maybe use an unfamiliar word. But in general, I would say no. I don't think that's necessarily related. But maybe if you're trying to get a child to speak more, but if you're going through like note cards and you're targeting like I don't know, R sounds and they're single words, then they probably wouldn't stutter more on single words. So it depends on how you're going about it. But probably.
All right, we've had a couple of questions about stuttering being more common in either more stressful or more emotional context, or actually also in less stressful. Do people stutter more sometimes when it's in a less stressful situation? Stutter less in a stressful situation, sorry.
Less and stressful. If you're like, some people might stutter less when they're emotionally charged and yelling and things like that. So that's been known. If they mean that. Shanley, did you have something to say?
Yeah, this is actually something we've talked about in the support group a little bit before. Like if you're really tired, do you stutter more or less? Or if you're happy or angry? And I think people all have different answers. I think different people who stutter more or less in different situations. I really think it depends on the person. This is a very like diverse population. So I really think it's different depending on the person.
But I think in general, any condition, any situation that really puts more burden on an already kind of vulnerable speech motor system, whether that is social, stress or cognitive, like you're trying to say something really complicated, for example, or what have you. I mean, that's all gonna create more of this pressure on this speech motor system that leads to more stuttering.
All right, I think we have time maybe for one more question. Is there a difference in how many boys versus girls stutter, and is stuttering hereditary?
Mm-hmm. So yeah, let me tackle this first, and maybe others can chime in more. There's definitely evidence to show that it is hereditary. The heritability estimates range from about 0.4 to 0.8. So there's seem to be a great influence of genetics, but there is room for environmental effects too. In terms of boys and what was the question about boys and girls?
Is there a difference in how many boys versus girls stutter?
Yeah, so as I pointed out in the first slide, when I gave the presentation, the sex ratio is about 3-to-1, boys to girls. Many more boys stutter than girls, and many more girls grow out of stuttering than boys do. So yes, so I don't know if that answers the question. But that's common in other neurodevelopmental conditions too. These conditions are more prevalent in boys than girls.
Great, thank you. I think we can kind of start to wrap up now. So thanks to everyone for joining us this evening. Before we finish, I want to open it up to our experts to give any closing thoughts or remarks if they have any. And we will also pull up a slide with some more information about the support group and our research lab and things like that.
Yep. So I'll start. So stuttering is not for example, cancer or something that could kill you, for example, but it is a condition that really affects a fundamental human ability to communicate with fluent speech. So it really affects many aspects of life, and it affects a large group of people. It's about 1% in the population, and that if you get to 1%, that's not considered a rare condition. Given these aspects, we still know so little about stuttering, and current treatments for stuttering is not very satisfactory. There's not a lot of good treatments that lead to I said there's no cure for stuttering right now. There relapse rates for stuttering after getting treatment in the case of adults, it's about 70%. So that's not great. So this is an area that is in need of a lot of research, a lot more research to first understand better the basis of stuttering that could lead to better development of newer treatments that really leverage updated understanding of how the brain works differently in people who stutter. So our lab is really motivated and trying hard to expand the research in this area, which is so needed. I hope that everybody can look through our website for more information. If any of you know of any children who stutter or adults who stutter, we're constantly looking for participants for our studies. That's actually the hardest aspects of our research, to recruit sufficient numbers of people who stutter. So if you know of anybody who might be interested in participating, we would really love to hear from them. So thank you so much for staying until the end and for your attention. I'll stop there.
Stanley or Anthony, you want to add any last comments?
Yeah, just if you're interested in the stuttering support group, please reach out, and thank you so much.
All right, well, thanks so much to our presenters for their insights, and thanks to all of you for tuning in and asking such thoughtful questions. We hope that you found the presentation informative, and like we mentioned, if you're interested in learning more about stuttering, our research, or the stuttering support group, there are QR codes up on the screen that you can scan. You can also reach out to us with a contact form on our website when you get to that. Yeah, but that was all we have for you tonight, and thank you so much for joining us, and have a wonderful rest of your evening.